Now we will hear from Dr. Naghavi, and he will talk about tuberculosis.
First of all, I would like to thank Dr. Minian Smith for her years of dedication and hard work that keeps bringing us together. This is now our 9th symposium and our health series to continue. I've been asked to give a brief talk on tuberculosis this morning. Tuberculosis is a bacterial infection that's been living amongst us for thousands and thousands of years. We have proof that it's been around for as long as 17,000 years ago in some animals that have been recovered, as well as we've discovered it in mummies in Africa and in Egypt, that it's within their spinal column and so on and so forth. It is a fairly opportunistic infection, and it tends to attack people who are more immune compromised. And this immune compromisation could be secondary to dietary malnutrition, or it could be due to secondary co-infections, or it could be due to HIV, and it could be due to immune suppression, whether it's cancer or other autoimmune disorders that Dr. Minion just touched upon. And a lot of, the majority of the tuberculosis is a late onset tuberculosis, where the people have been infected and exposed to the infection when they were children through some sort of a close contact with relatives and close living, and then it resurfaces when we become older or we become weaker in our lifetime. We are experiencing approximately 10 million new cases a year. And in that 10 million new cases, we expect, or we estimate, that the majority of them are latent or late onset or recurrence of exposure to become opportunistic infections. It is a killer. It does kill about 5% of those who become exposed or activated, and it's usually secondary to drug resistance, TB. It is more of a killer in children. We've had about 1 million cases, more or less, a year in children, maybe children born to HIV mothers or immune suppressed family members and such, and it seems like it's a bigger killer in children. Up to a third or 25% of them will die. Just some overviews of tuberculosis and its presentation. Tuberculosis usually comes along with some weight loss, some night sweats, some cough, sometimes a bloody cough. It could come also with pain in the chest and in the pleura, and so on and so forth. Tuberculosis also has other types of infection besides pulmonary infection. It could also come in the form of, as I was saying, in a bone, where it will be sitting in spine or in nerve endings, mostly skeletal bones, the column bones of the spine, and so on and so forth. So, and these are again secondary to people being more immunocompromised, allowing it to travel more readily through the body and sitting in one particular position and coming out. And so you may have somebody who presents with back pain and weight loss, and there may be no cough at all, or it could just be back pain. I think one of the things to realize about tuberculosis is that it's a very slow growing bacteria. Usually bacterial load or numbers double every hour. This particular bacteria doubles every 18 to 20 hours. And it's a very resistant bacteria. In other words, it can sit on surfaces in a dry position for a very long time. If the surfaces are not nicely cleaned, once it comes exposed to a host, it will wake up and would start to duplicate. So it's sitting dormant, slowly growing, more difficult to get rid of unless it is pushed around and killed by more disinfectants and so on and so forth. It can also be present in the nervous system. So somebody could present with meningitis type of it, or it could be presented as a result of neuropathy, and you may really think that, oh, maybe this person has shingles or has a problem with their back and so on and so forth. About 10% of them can really be all over. So not only you could have it in your organs, you could have it in your bone, you could have it in your gastrointestinal tract, you could have it in your lungs, and so on and so forth. So really, it's something that needs to be treated aggressively, treated with multi-drug resistant. Well, let me touch upon multi-drug resistant. TB has evolved over the period of time, in the modern time, that we have realized that, okay, we have one drug and it used to treat the TB, now we have two drug combination, and that maybe is more effective, or now we have three drugs that are combined, and maybe we have four drugs that we put together to try to catch the different angles that these come with. So in the modern age, we have realized that as we diagnose TB, whether it's through sputum or other sources, that we also check them for multi-drug resistant TB. So usually if the drug is resistant to rifampin, it is showing the extent and the strength of the disease and how it can be treated effectively. And the multi-drug resistant comes around as a result of that. The next thing is, as far as the initial diagnosis of TB, I think is the most important thing in today's world. As I said, this is an opportunistic infection. It is sitting with people who are immunocompromised. We're seeing an insurgence in the United States in school children population that have been migrants, or the second generation where the children have been exposed to an older family member. In the old days, we would see people who came from other countries that were vaccinated with BCG vaccine, and we would think that everybody who was exposed to BCG may or could turn out to have a positive skin test, a tuberculosis skin test, but now we realize that that is not good enough for us to just do a skin test and say, okay, these people were vaccinated with BCG, let's leave them alone. Let's just do a chest x-ray, and if the chest x-ray is negative, let them roam around in the population and let's presume that they're not affected or infected with TB. TB presence is as much as a quarter of the Earth's population could have been exposed to tuberculosis. So the problem becomes, amongst us, at least a quarter of us has been exposed to the bacteria of TB. So it becomes a search and kill situation. So yes, you could use, a PPD or skin prongs and so on and so forth to try to screen who's been exposed or who's been vaccinated. Only about or you can also do a blood test called TB Gold Quantiferon. The blood test has become very popular in the past decade, and it's sort of given us an insight as to who's been exposed to TB and who's been vaccinated for TB. who is a false negative and who is a false positive or true positive. So we try to give more of an assistance to see who may be exposed. So in my own practice, I check patients for TB gold quantiferon, even if they come for a job physical. Instead of doing a PPD on their arm or a Montauk test, I would just check their TB gold and say, this is more important and more accurate. The job wants it, okay, we'll put a PPD as well. But because we don't know if they got BCG vaccine or whatever the case may be, if there's, migrants, if the TB gold quantiferon comes back positive, I treat these people. Not for an active TB, for a latent TB exposure that could awaken 10, 20, 30, 40, 50 years later. So we can, if they have no symptoms, if the chest x-ray is negative, they are not coughing, they're not having weight loss, they're not having bone pain, then I just treat them with isoniazid, 300 milligram once a day for up to 6 months, along with B6. If they're positive, as far as the chest x-ray is concerned, they have, cavitary lesion or lesions in their lung or so on and so forth, then I just bring in somebody more comfortable to using multi-drug regimen and making sure that they're monitored. A lot of the problems we have with tuberculosis treatment is actually verifying that these people took their medicine, that it actually worked. We have no tool to say, okay, you have seen this bacteria, your TB gold quantiferon is positive, we documented that you took a 6-month treatment of INH, but did you really take your medicine? Was it really INH that you took? Or was it calcium pills that they gave you and they said these are INH? Because you don't know where you buy it, and if you're outside this country, so you can't rely on the medicine either. So those are the challenges that we have with tuberculosis. Again, it's an opportunistic infection. It is amongst poorer socioeconomical areas of the world. Far East is the most common, whether it's Pakistan, China, India, Indonesia. Africa is only about 25% of the new cases are coming out in Africa. We are seeing an insurgence of the numbers in the United States and in the modern world with the migrations and migrants from South America or other parts of the world or Africa or Asia. Usually, before they issue a visa or an immigration visa to somebody, they would ask them to do a chest x-ray, they would do a Montauk test or whatever, but again, it can escape. Vaccination doesn't mean cure or doesn't mean prevention. Only about 10 to 20% of people who have been vaccinated can escape and not get the actual infection. Drug treatment doesn't mean that you took the treatment, it means that you hope that you took the treatment. Taking the treatment for a long enough period of time means that hopefully you were compliant and there was no other problems. But you do have to monitor the liver enzymes for these patients to make sure that they're not having drug toxicity. A lot of the medications or combination medications are cleared through the liver, so you could develop hepatotoxicity and liver problems that will further complicate things because you'll have to stop and allow things to go back to normal and then try a different route to try to see what other medications will work. Also, don't think that because we live in a nice area, we're not from close quarters or we don't have job exposure, that we're not at risk. Because if any of us are taking immunosuppressants for autoimmune disorders or arthritis, we're just as immune compromised, as maybe not as bad as an HIV patient, but compromised enough. If any of us are planning or have gone through chemotherapy, that's the time that we become immunocompromised, and that's the kind of time that we're going to run into problems. So realize that all of those things can affect it. Also, diabetes will affect us to make us render us more weaker. The same way that Dr. Mignon explained, refraining from alcohol and refraining from food that is bad will help us build our immunity. Drinking alcohol, being a diabetic, smoking cigarettes, being overweight and so on and so forth, those are all risk factors that will push our immunity downward. I think that sort of brings me to a conclusion on a brief oversight or overlook of tuberculosis. Thank you very much.